Thank you everyone for joining our webinar today. All participants except the panelists and presenters will have their video turned off and audio on mute for the duration of the session. Please use the Q&A panel to add your questions or comments. Please note that this virtual event discussion will be recorded and a few screenshots will be taken for the purpose of documentation and reporting. Thank you in advance for your consent and cooperation. We will be sharing a recording of the webinar along with the PowerPoint presentation to all attendees at the end of the webinar, and these resources will also be available on our website after the webinar. Imran Bhai, we're now live, so whenever you're ready, please go ahead.
Great. Okay, thank you very much. Thank you, everyone. Because we have a number of our discussants and also participants from around the world, so we're going to conduct the whole thing in English. But of course, in question and answer, we'll have opportunity for anyone who wants to come in with, speak to in Bangla as well. Great. So, so today's BIGD webinar is on COVID-19 vaccination, where we are going to be looking at willingness and practice in Bangladesh. I just want to start off by saying that this is a obviously extremely it's a multidimensional complex behavioral phenomena. This has very important supply side dynamics. In this study, we have not considered the supply side aspects of this, which is really important, especially in this particular COVID-19 vaccine context, in the kind of vaccine diplomacy and vaccine nationalism and the market oriented mechanisms, the wonders of the market and also the limitations of the market that we are seeing are all issues that we are not really going to be talking about today, but we can bring it into the discussion, of course. But the research has not been on the supply side. The research has been focused on the demand side, and within that also, we are a social science research institute, so our focus has been looking at the demand side more from a socio-economic lens rather than a public health lens. And I guess public health specialists would look at it differently, and we can bring it into the conversation in terms of what does the socio-economic lens add, what does it kind of distract from, and what are the other additions that is really required for us to get a better perspective even on the demand side. So I just want to kind of really start off with that. Secondly, this is a study that was basically done in a very opportunistic way, because we were doing a number of surveys for some other research topics, and but we very opportunistically added vaccine module to a number of these surveys, and we've harvested data from those different surveys in order to really understand or add some insight to this particular issue. Finally, I would like to also basically say that from a method point of view, it's been really interesting, because it wasn't really planned, but it just happened that way, that there were some surveys that we did in February, and then we managed to do repeat also in March. So that these two time periods were very, very interesting and important. Though it's just 1 month, what it allowed us to do, February was when this was the whole vaccination. There was a lot of optimism around vaccination in some ways, though it hadn't actually started. By March, vaccination had started. However, I think some from the global media, there were lots of skepticism in terms of its effectiveness, safety that was emerging during this whole month from sort of February to March. So in some ways, it allows us to look at some of these how these have affected people's willingness as well. Obviously, we haven't been able to do the panel for each and every case, but for certain samples, we've been able to do that, especially for youth, as you would see. I think we will talk about that. So I don't want to talk more on this. I would now like to hand over. I'll come towards the end later. I'd like to hand over to our researchers who have worked on this. We've got Menaz Rabbani, who's a lead research for policy and governance at BIGD. Abhinno Farooq, Research Associate, and Ishmael, Research Associate from BIGD. I don't know how you guys want to order this, but who wants to start off?
I'll start. Thank you, Manbhai. Okay, thank you. Welcome, everyone, and thank you for joining us today. We are well into the second year of this current pandemic. In Bangladesh, we, like most of the world, are embracing ourselves to face the second, third, and I don't know how many more waves of COVID-19. While the prescribed health safety measures in our daily lives can ensure some safety for us, ultimately, what will save most lives and take us back to our old normal is vaccination. Bangladesh was one of the first countries to start vaccinating our population. Can we move to the first slide? The government of Bangladesh has announced a target to vaccinate 80% of our population in phases over time. Now, mass vaccination is not new to Bangladesh. We have terrific success stories of mass immunization programs, EPI, for example, the expanded program on immunization for children. We know how to do this. But an adult immunization target of this sort in this situation, given the time crunch and the cost associated with casualty per day is very high. This is a new experience, a new phenomenon, and certainly a challenge for the nation. In earlier mass immunization programs, we had the luxury of time. We had time to distribute, deliver vaccines nationwide, and also motivate people to get vaccinated through long-running communication campaigns. Although there is much talk about supply-side problems right now, COVID-19 vaccines, we also need to think about the demand-side factors. On many instances, we have heard in our circles stories about how a lot of people around us are not too eager to get vaccinated. They're not too sure, despite the fact that at the beginning, getting vaccinated was very easy and free for us. So in this research report, we focus on the demand side for vaccinations. We will be presenting to you findings from the data that was collected in the earlier months of this year on vaccination acceptability and behavior and practice in terms of registering for vaccination. Moving on to the next slide. So the objectives of the research was to identify demand-side barriers so that we are aware of what issues need to be tackled to achieve that 80% national target for vaccination. We find that willingness and registration behavior varies across groups. Our results will hopefully help identify subgroups within the population who may need targeted interventions to get vaccinated. In addition, we want to also understand how willingness to vaccination translates to actual registration and getting vaccinated. So what are the factors that are playing a role in this process? So in the next slide, just moving a little backwards, looking at the statistics from our DGHS. This picture here shows that the number of people who received the first dose of vaccination in the first 3 months of the year, it rose and then it fell again. At the beginning, when the vaccine became available, as Imran Bhai mentioned, there was a lot of enthusiasm. In February, the number of vaccines administered, we saw a rise. Okay. Although certain sections of the population were very quick to register and get vaccinated, we didn't really see a huge rush of people or long lines as we see in pictures in other countries. Despite availability of the vaccine at that time, the daily numbers started to fall after February. Even after the age bar, the official age bar was changed from over 50 to over 40. So in order to achieve our 80% target, it is obvious that the daily vaccine administration number has to pick up drastically so that we can ensure faster coverage. So given this premise, I will hand over to Abhinno Farooq, who was one of the research associates who worked on this project, will now present to you the findings of the research. And I will come back after her to discuss briefly the implications and takeaways from our findings. Abhinno?
Thank you, Manazaka. So the layout of our presentation today is going to be as such. Firstly, I'll be discussing the various samples that we have used to prepare this particular report. And then we move on to our analysis part, which is mainly going to be twofold. In the first part, we talk about the willingness to be vaccinated for 3 specific samples. First, we have our nationally representative sample of the adult population, which we will be referring to as general here. And we also have youth and urban slum samples. In the second part, we mainly focus on the practical aspects regarding vaccination, which is the prevailing registration behavior and practices. And lastly, in the end, we talk about some policy messages based on our findings. Can we have the next slide? So the data for this particular report had been drawn on from 3 different phone surveys, which had been conducted over various periods of time early this year. The first one was the State of Governance 2021 survey, which had 3 sampling frames. The first one was the national representative general sample of the adult population, and we also had youth and urban slum samples. The second survey is called the National Youth Survey 2021, which was representative of the youth population aged 18 to 35 years old. And lastly, we have the third round of the livelihood coping and recovery during COVID-19 survey, which had 2 samples. The first one is nationally representative of the rural population, and the second one is for urban slum residents. Can we have the next slide? So our surveys actually fell in line with a lot of interesting developments in the Bangladeshi vaccination scenario. For instance, our first survey was able to capture the arrival of the vaccines from India, and we remember there was a lot of hype around it, as many people were very happy that we actually got the vaccines before a lot of other countries. And then we also were able to capture the willingness during the trial run and the early initial phases of the vaccination of the mass immunization program. And the excitement was apparent on social media. We remember seeing a lot of photos there. However, over time, due to some concerning global developments, such as whether there were questions raised, whether the vaccine will be effective against the new variants, and there was also the blood clot issues, skepticism grew over time. So our latter surveys actually were able to capture these factors. For instance, the one we did in March was able to capture the actual behavior as opposed to the expressed willingness. So the actual take-up of the vaccine was covered. I would also like to note here that we only were able to capture the first dose, and we did not cover the start of the second dose, which I believe started on April 8th. Can we have the next slide? So now I'm going to talk about the willingness to be vaccinated for the national representative sample we had, and this survey was conducted in early February. Next slide. So the first thing we note here is that 83% of the national representative sample were actually either definitely willing or probably willing. And as already mentioned by Mehnaz Appa, that the government's target was 80% of the population. So initially, it did seem like demand side won't be a problem in early February. And we also note that a higher percentage of people were actually willing with certainty, and those that say that they were probably willing can probably be convinced to take the vaccine ultimately. Next slide. So we then asked our unwilling respondents that why they do not wish to take the vaccine. So the most common reason they cited was that they do not feel the necessity of the vaccine. And this was followed by they have no trust in the vaccine, or they have concerns regarding its effectiveness and side effects. And it is also worth mentioning that those who say that they are definitely not willing to take the vaccine, a higher proportion of them do not feel the necessity of the vaccine. Next slide, please. So in rural areas, the willingness was actually surprisingly higher compared to the urban regions. And when we disaggregate by gender, we do not find much significant difference in terms of willingness. Next slide, please. So people who feel that they have a higher health risk, or they are more vulnerable to contracting the COVID-19 virus were more willing to take, definitely willing to take up the vaccine. And when we asked them regarding their family members, people who say that who think that their family members are more susceptible or more vulnerable to contracting the COVID-19 virus were also more definitely willing to take up the vaccine. Now I will talk about some governance indicators and try to see whether it has any relationship with people's willingness to take up the vaccine or not. So first off, we note that people who tend to think that there were more irregularities involved in the relief distribution system were less willing to take up the vaccine. And on the other hand, can we have the next slide? Which one can we have the next slide? Yes, thank you. So on the other hand, people who were more satisfied with the government's relief distribution were more likely to say that they would be taking the vaccine. And lastly, we asked them regarding their confidence in the efficiency of the distribution of the vaccine in Bangladesh. And people who said that they were more confident in terms of the distribution were more likely to say that they would be taking up the vaccine. So overall, we see that people who had higher trust or faith in our public service delivery system, who had a better impression regarding the government's service delivery system, were more likely to take up the vaccine. Next slide, please. So now I talk about the willingness, but in this case for the youth, and this the data for this particular analysis comes from 2 different samples. Can you have the next slide, please? For 2 different samples, and the first survey was done in early February, and the second survey was done in early March. So we basically have the change in willingness 1 month apart. And the timeline for this particular survey actually fell in line with a lot of concerning developments and unclear and negative news in the media, such as we already mentioned that there were concerns regarding its effectiveness against the new variants that were coming up, and also there was also the news of a death supposedly reported after taking the AstraZeneca vaccine. And it is also reasonable to assume that the youth being very much active on social media are more exposed to global developments as well as other types of misinformation, which are very much prevalent on our social media. So as a result, it would be interesting to see whether their willingness got affected as a result or not over time. So can we have the next slide? So we do actually see that the youth's willingness actually fell by 13 percentage points from February 2021 to March 2021. And at the same time, their vaccine hesitancy rose by 7 percentage points. Next slide, please. So now I talk about willingness, but for the urban slum dwellers, and this survey was again conducted in early February of this year. Next slide, please. So the first thing to note here that was the urban slum dwellers are much less willing, in the sense that if you look at the proportions of definitely not willing, urban slum dwellers are more likely to say compared to the overall general urban sample. The urban general sample comprised of slum as well as non-slum residents. So we do not see much, the previous, yes. So we do not see much difference in terms of the definitely willing proportion, but they were far likely to say that they are probably willing. So this is probably something that needs attention. Next slide, please. So again, we also asked our unwilling urban slum respondents that why they do not want to take the vaccine. And the concerning thing to note here is that a higher proportion of them are unwilling because they do not feel the necessity of the vaccine compared to the overall urban sample. We see that this response was cited by 75% of the unwilling urban slum respondents. Moving on. So we also asked them regarding how confident they are in the efficiency of the vaccine distribution in Bangladesh. And what's interesting here is that they are more likely to have stronger views regarding it. They are more likely to say that they are not very confident at all. And at the same time, they're also more likely to say that they're very confident compared to the overall urban sample. Next slide, please. So now we move on to our second part of the analysis, which is the prevailing registration practices and behavior. So this particular survey was done towards the end of March, and 1.5 months of the mass immunization program had already passed by now. So it was a good opportunity to evaluate and examine what is happening on the grounds. Moving on. So this is our decision tree for the vaccination process, and we actually based our questionnaire based on this. First, we asked our respondents that whether they have heard about the vaccine registration or not. And those who say that they do not know about the vaccine registration were not asked any further questions. Concerningly, about 1/3, 35% of the samples say that they have not heard about the vaccine registration. And among the 65% that did hear about it, 59% did not actually register despite hearing about it. And we also know that 28% were actually eligible. Despite that, they did not register for the vaccine. And around 70% were unsure about their eligibility criteria. And among those that did, among the 5.9% that did end up registering, only 3.8% of the total sample actually ended up taking up the vaccine. So now I'll talk about each segment and mention the interesting highlights regarding them. So first, we focus on our registration knowledge, whether they have heard about the vaccine or not. And we see that, can we have the next slide? As noted earlier, unfortunately, 1/3 actually did not hear anything regarding the registration. So compared to rural respondents, urban slum respondents had heard about the registration process more. And compared to women, men had heard about the registration process more. So rural respondents and women were falling behind in terms of information. In terms of occupation, certain occupation categories such as the homemakers or the unemployed and certain informal sector workers also had the least information regarding vaccine registration. Next slide, please. So then we asked our respondents, those who have heard, that what was their source of information. And around 80% said that they had heard it through their informal networks, such as their friends, relatives, or neighbors. And the second most common response we received was mass media platforms such as television and radio. Interestingly, only 10% said that they had heard it from social media. So it's quite clear that at least for the rural and urban slum samples, social media is not a very, it seems like that social media is not a very effective communication platform as opposed to our informal networks or traditional media platforms such as television and radio. Next slide, please. So then we also asked the respondents who said that they had heard about the registration, what sort of information, vaccine-related information, do they want to know more? And unfortunately, again, 40% actually said that they do not need or they are not interested in any further information. And among those that did want to know, 40% said that they want to know how to register for the vaccine. So again, going back, we noted earlier that 35% did not hear anything about the registration. And among the 65% that did hear about it, 40% still don't know how to register. They don't have the detailed information or the step-by-step guidelines regarding how to get themselves registered for the vaccine. And lastly, the other information that people wanted to know was where they should go to take up the vaccine or whether they would be charged any money for it or not. Next slide, please. So now we focus on the people who have heard about the COVID-19 vaccine registration, and we see whether they have registered or not. And here we find that, can we have the next slide? Here we find that in rural areas, the registration rate for men were higher compared to women. However, among those who said that they were unsure about their eligibility, this proportion was higher among men. So again, going back, we noted earlier that women had less knowledge, less information regarding registration. But it appears that the women who did have knowledge, they had at least the proper knowledge or the precise knowledge regarding registration compared to men. And the people who did hear about the registration, among them 25% were not sure about their eligibility criteria, whether they can sign up for the vaccine or not. And again, we note certain occupation groups such as the homemakers and informal sector workers such as day laborers or housemates having the lowest registration rates. Moving on. So then we asked the respondents who had registered that how did they register themselves for the vaccination? And it appears that most of the respondents had either done it online, but with the help of another person, or they had gone to a shop to get themselves registered. So it seems like most of our registration had occurred by a secondary means. And it's also interesting to note that compared to urban slum respondents, rural respondents were more likely to get registered themselves on their own. But the people who registered online with the help of someone else, this proportion was higher for urban slum respondents compared to rural. Next slide, please. So now we move on to those who did not register, and we focus on the eligible respondents who still did not register despite knowing that they were eligible for the vaccine. And we try to see, can we have the next slide? We try to see the reasons regarding why they did not register. So this is the reasons cited by the eligible respondents who did not register themselves for the vaccine. And unfortunately, the most common response that we received here was that they are uninterested to take the vaccine. So again, going back, 1/3 doesn't know about anything about the registration. And those that did know, among them 40% still don't know how to get registered. They don't know the detailed information. And among eligible respondents, those who did not register are not interested to take the vaccine. And this percentage is significantly higher in the urban slum respondents category. So this is quite consistent with our early findings where we said that the lowest willingness was observed in February among urban slum respondents. And other, can we have the previous slide? And other reasons that were cited by the eligible respondents for not registering were that they could not manage time or they do not know how to register, as previously pointed out. Moving on. So now we look at our eligible respondents and see whether they have registered or not. But in this case, we disaggregate them. Ishram, can we have the next slide? In this case, we disaggregate them by their pre-pandemic poverty status. And we see that those who were extremely poor or moderately poor had a tendency to not register, despite knowing that they were eligible for the vaccine compared to our respondents who were vulnerable non-poor or non-poor. Next slide, please. And lastly, we move on to our registered respondents, which was only 5.9%, and try to see whether they did end up taking the vaccine or not. And here we see that there was in general an overall high level of compliance. But again, I would like to mention that a very low percentage of the total sample had registered to begin with. And in the final slide of our analysis, we asked our respondents that the respondents who did take the vaccine, that what was their source of encouragement. And interestingly here, we again see that our social networks or our informal networks have been very influential in this regard. And another interesting point here is that our friends and colleagues were more influential compared to our relatives or neighbors, for instance. So this is also a very interesting finding. I would now hand over to Mena Zappa to continue the rest of the presentation. Thank you.
Thank you, Apino. So just wrapping up and reiterating the main takeaways from this research, we find that willingness to get vaccination, in answer to the question, if there was a vaccine offered to you for COVID-19, would you be willing to take it? People are willing. 80%, more than 80% said yes. So willingness to get vaccinated is not the problem for us in Bangladesh, right? With the right kind of communication, motivation, and delivery, we should be able to reach our national target of 80%. However, as Opino said, 35% of our sample did not even know about the registration, COVID-19 vaccine registration. They simply haven't heard of it. A meager 5.9% of our sample had registered for vaccination by March 2021, and only 3.8% had taken the first dose. So for example, in our livelihood sample, out of the people who are aged more than 40 years, only 9% had registered. Over 20% of this group were unsure if they were eligible. So what we see here is there's some confusion in communication. People are not sure. Even if they're willing, they're not sure about how to register, if they're eligible, etc. So, but on the other hand, we see that people who do register, they get vaccinated. There's no dropout there. So the weak link here is getting people to register. So people are willing, and once they register, they take the vaccine. So going from willingness to actually registering, there's where the gap is. So our survey is pointing to the fact that there is a lack of clarity among people, even if they are aware of this vaccination. A lot of people are confused about their eligibility, how to register, where to get vaccinated, etc. So it looks like we need a more effective mass communication program in this scenario to motivate people to get registered and then get vaccinated. Going to the next slide, our results indicate that youth and people in urban slums are possible target groups for a communications program. The fact that the willingness to get vaccinated among youth had decreased over the span of 1 month is of concern. This is something we need to understand and address better. In urban slums, the strong unwillingness to get vaccinated is something that needs attention. Here, most people said that they don't need to take the vaccine. So we need to think about how to convince this segment of our population of the benefits of vaccination, especially in the context and environment that they live in. They're more vulnerable and susceptible to contracting the virus. Although we often get the impression that mass media, social media are good ways to reach out to people in mass awareness campaigns, we find in this case that informal personal networks have been the most influential channels for information. People have been informed and motivated to get vaccinated mostly through their family, friends, and co-workers. So that's another thing that we need to keep in mind if we're thinking about how to communicate with people. Another interesting finding from the research is that general perceptions on efficiency of public service delivery is an important factor. People who trust efficiency of public service delivery are more likely to respond positively to mass vaccination initiatives. So in summary, we see that willingness and practice of vaccination varies by different groups and also changes over time. So our success in fighting this pandemic is dependent on how fast we can reach our 80% target for vaccination, right? So to do this effectively, we need to think seriously about a targeted and dynamic communication strategy. We hope that this research report gives some indications of where to focus and also highlights the importance of further work to better understand what makes people get vaccinated. Thank you. I'll hand over to you, Imran Bhai.
Great, thank you. Thank you. Great. So I think there's a lot of things there to really reflect on and discuss. So let's move to the discussions. We have do we have Masoom Billah who's joined or not yet? Zareen, can you?
Not yet. Not yet.
Okay. So let's wait. Maybe he will come towards the end. So let's start with Diana, Professor Diana Mitlin, Professor of Global Urbanism, Global Development Institute, University of Manchester. So Diana, I mean, you're free to talk, on any aspect you like. But what I would really like to hear from you, perhaps reflecting on the urban dimension that we basically find here. Especially the urban slum dimension, because you have done a lot of work globally. What are we finding? Is there, is there similar type of findings or not? And then if you could link it up perhaps with this public perception of public service delivery and trust in public service delivery, whether that linkage is also, if you could unpack that a bit more for us from global research. Diana, over to you.
Okay, thank you so much, Imran. It's a delight to be here. I really appreciate the invitation. So a few things jumped out for me of the presentation. I think firstly, the importance of a practice of vaccinations, the importance for people of having that history of having been previously vaccinated and falling into an established pattern of behaviour seems important to me in other contexts. So certainly when I was learning from experiences in Africa, that was repeated to me. The fact that where people have a practice of being vaccinated, of taking their children to be vaccinated, that practice can be used in this case to reduce anxiety related to COVID. I think from the early reports on your early comments around the research, something also jumped out, which is the importance of messaging and the importance of building that sense of excitement by health services that go out to vaccinate and trying to build an excitement about the process to overcome concerns. And you talked about the negative stories about blood clots, which have been concerning everywhere. And of course, potentially there will be more concerns emerging. Some entirely spurious correlations, but nevertheless, very concerning. I don't think your urban findings were a great surprise to me. They indicate certainly a suspicion of government. We know that those who live in informal settlements, unfortunately, are often badly treated. They are promised services, and those services are not delivered, or are delivered of a very poor quality. And in that context, we have a history of suspicion that is clearly seems to be problematic here. That's not to say also that you don't have a small minority of people in those areas who are better informed, who are well-informed urban citizens, who perhaps have read the documents, who understand the risks, but this undercurrent of suspicion goes back for decades of neglect and continuing neglect. I mean, you highlighted this issue of trust for me to talk about, and it's something which really jumped out for me, because looked at the other way, I would say we see in many other contexts where communities have built a trusted relationship, where they have local officials that they can engage with, they can get clarity about. That seems to be really important in building a confidence, in getting a better engagement, in encouraging community members, perhaps even just to reach out with their questions and have a response. So in a sense, it's both a challenge to you because you're seeing people's reluctance to do that, but it's also an opportunity if government from their side recognize the importance of building those trusted relationships, of potentially seeing COVID vaccinations as a way of doing that. And one of the things I've seen operating quite effectively in the UK in low-income suspicious communities is where vaccination services really reach out to people. I mean, on the one hand, surge vaccinations where vaccinators are going door to door, but also just pop-up vaccination centres. I'll come back to this at the end, but I do think if you can catalyse a change in relationships through vaccination, that is indeed a very interesting idea, which might encourage your health services to reach out and might help to change practices. I guess I was also struck by your findings around the fact that people need to know they can register. So they need to know about the idea of registration, and they need to know the fact they're eligible. And those, I think it's very useful that your researchers broke that down into those two stages, because people may hear about it, but assume it's not for them. And or they may not even hear about it. And the very high numbers of people who have not heard about it must be really concerning. I think I think you rightly said, okay, let's think about how we can build an understanding of registration and build an understanding of eligibility. And you talked about the importance of these informal networks, the importance of friends, neighbours, family, etc. And I think this is where, somewhat anecdotally, these ideas about pop-up vaccination centres are interesting to me, because the experience, I think, there from the UK, this is not looking at the global south, where this rollout has been much less, particularly in Africa. But people who've done those pop-up centres in the UK find that a large number of the people who come say things like, I was too uncertain to go, I got phoned up, or I was offered a space, but I didn't want to take it up. They're in a different context. They see others who they associate with. Clearly, if it's in a supermarket, they're not necessarily with friends or family, but they see people in their community having it done. It becomes a more normal practice. They begin to think, okay, well, look, that person's like me and they're having it done. I don't have to worry. They see the queue and they think, there's buy-in here. I can go join the queue. So not only does it reduce the time taken, people don't have to pay for transport. They don't have to go into a health centre where they might be a little bit nervous, but it increases the familiarity, it increases the convenience. And if they have it done, then they share with their own family and friends. So potentially it has a ripple effect. So to conclude, I think it's really exciting that the Bangladesh government is so ambitious in its efforts. And it's very helpful to them, I think, that you have been able to look so closely at demand and understand the handicaps and understand what needs to be overcome. I think there are clearly fairly straightforward things: how to get more people registered, how to get more people to understand eligibility. But within that, the challenge of changing relationships. So trying to catalyze the informal connections to build up a demand, but also recognizing that being vaccinated requires a level of confidence in health services, because you are putting something into your body that is foreign, and seeing that trust relationship, seeing that state-civil society relationship, that state-society relationship, that state relationship with groups who have been marginalized and disadvantaged, is an opportunity for more substantive change, as well as an opportunity to get Bangladesh back after this pandemic crisis. So in summary, I think you're pointing out really important and interesting things. And thank you very much for the presentation. I really enjoyed it.
Thanks a lot, Diana. You brought out really, I think really, interesting ways of looking at the results and sort of connecting, the kind of, in some ways, the sort of the plumbing, the focus on the getting the plumbing right, but also the fact that, to get this plumbing right, you need to focus on some pretty fundamental things as well. And they can be focused in a very service delivery oriented way, but the effect of that can actually be quite substantive in terms of almost having a kind of a new type of a social contract, if you like, between urban citizens, urban low-income citizens, so primarily where a lot of this sort of challenge is, and the state. So I think those are extremely kind of I think useful ways to think about this problem. Let me now move to Dr. Shakira Sultana, Deputy Program Manager, Expanded Program on Immunization, Director General of Health Services, Ministry of Health and Family Welfare, Government of Bangladesh. Of course, I mean, again, you are free to speak, on any dimension. But given that you are you are sort of quite well versed and kind of have been driving the expanded program on immunization, which is Bangladesh is such a success in this area. I wonder if you can think about, okay, what is it that we can learn from that expanded program of immunization where we are so successful, and the COVID vaccination? What can we learn in the context of what we have been talking about? Dr. Sultana, over to you.
Thank you inviting me as a panelist. I need to correction two things. Actually, our government has targeted population because we have get only previously from the Covishield vaccine, about 1 crore, 1 million, and the Pfizer is only Pfizer is 50 lakhs, so 1 crore. Pfizer is 1 crore, and we are getting the another group of vaccine, like we are getting Sinopharm, and as well as Johnson and Johnson. So it's targeted population fixed by the NITEC and others government high official who will take vaccine, who will give vaccine, and it's totally on government. And as we all know, our we have shortage of the vaccine. So from government procedure, government told us to slow the communication process, because now already we are in that situation. Lots of people come to us and they all are like, in your research, we find that willingness is not a problem. So everybody wants to get vaccine. It's the government procedure to slow the communication. When we have available all types of vaccine, we are planning to vigorously communicate, then all the people registration process, and they know about the vaccination. That's from my correction. And you already know about the EPI, one of the most successful program. And during COVID situation, we also maintain our coverage above 80% throughout the country. That's from my side. Thank you.
Thank you. Thank you. Thank you. Thank you very much, Dr. Shakila. Is there, do we have the third presenter, sorry, discussant? Otherwise,
not yet, Imran Bhai. I think maybe we could do just a round of question and answer sessions.
Yes,
Yeah.
let's do that. I think there are questions, but I wanted to actually, there's a very interesting comment here from Dr. Mirza Hassan on, you know, this, you know, I mean, I think it's really a comment on, you know, kind of the, sort of in many ways how our, you know, our, in many ways our evidence-based approach, and, you know, not, you know, our perception don't seem to be, you know, particularly colored by, the kind of social media, disinformation that's basically going around. Mirza bhai, would you like to build on that a bit more?
Mirza bhai, you have permission to speak if you would like to unmute.
Okay, now can you hear me?
Yeah.
Okay. Now, I was just thinking, I was looking at it, all the evidence, you know, there's so many mundane problems people cannot register. People are afraid of, having some kind of, medical problems if they take vaccine, and there are poverty issues and all these issues, but not a single issue in terms of ideology. That's fascinating. Even in a country where you have huge influence of Islamic ideologues and so on, and nothing from there. Just compare it, to US particularly, and some European countries where you have anti-vax, you have conspiracy theory, ridiculous conspiracy theory, anti-science conspiracy theory, and also religious, even in India, but nothing in Bangladesh. And there is an influence of social media, as we saw in the survey, especially among the educated youth who are heavily into social media. Those kind of influences, I'm sure they heard of it, they saw it, all those anti-vax movements in the Western countries, but they were not influenced, and that shows some kind of interesting cultural pattern in Bangladesh, where some kind of ideological shield, if you like, that protects Bangladesh from that kind of negative ideologies of the West, and probably from India too. So that was my immediate observation, and I'll come back if I have more. Thank you.
Right. Great. No, thank you, Mirza bhai. And I think it would be really fascinating to kind of perhaps look at the results of this work that we have done in a more historical context of vaccination in Bangladesh. There's obviously a lot of other kind of really good literature available on vaccination in Bangladesh. It'd be really fascinating to kind of draw that kind of larger narrative about vaccination. I think that would be really, really fascinating. Now, I think there was one question that I saw here, and I wonder whether the researchers could answer. So one is, do we have any findings on what percentage of participants have known about vaccine and registration from the NGO sector? Do we have that information? Is that broken up by that at all? Can someone answer that? Abindo or Ishmam? Abindo?
Abindo,
you're on mute. You're on mute.
I don't think we had a category of responses.
So I'll just
Yeah, so unfortunately, we did not have that option regarding source of information for NGOs. So we have not been able to capture that.
Right.
But it's not something that people, we did have, the answer option was open. So nobody really answered NGOs. That's why
So
we didn't
we
have
have, we had an others option for an open category answer, and only around 2% cited that. So I guess NGOs fell under that.
Okay, all right. Okay, so yeah, so NGOs, we have this other category, so we don't really didn't ask that specifically, but it did not come up as in the other category where there was an option. If it was important, it would have come up, and we know the NGOs haven't really, and that's the sort of other, I think, an important kind of a lesson or important, kind of where we are right now. And I think going forward, we need to really harness, what is, what exists as the best in our overall public service delivery, which is a multi-actor oriented approach, where we combine, the verticality of the state delivery with the horizontality of the NGO and other community-based mechanisms. And unless we harness all of this together, we'll not be able to crack it. So I think that's very clear. But until now, it has been, and I think this was a bit remarked by Dr. Sultana, that I think primarily because of the supply side constraint, there was actually not a all-out campaign that wasn't really done in that way, and neither was there all-out service, kind of a mass service delivery kind of a design that was done. But I think going forward, we'll have to think about all of this, very, very, very quickly and very carefully, and we need to use this time that we have right now to really design these things, urgent. I think there's another question. What measures our government can take to ensure availability of vaccination? I mean, I don't think we can really answer this from this research. We'll be getting into the realm of opining, and that's something we like to resist ourselves from. Let us, stick to the research. The question is absolutely important, but I don't think we are we have enough anything from the research to be able to talk about this particular point. Great. Do you have any suggestion how can NGO in public sector play their role? Yeah, I mean, I think I sort of talked a bit about that. And I think they will have to. I think if we really learn from the way our vaccination drive has been successful, and I think Diana also talked a bit about this pop-up and taking it close to the community. We know this. Right? You have to take it close to the community to be able to deal with the suspicion. And for that, we need a multi-actor oriented approach. Bangladesh is extremely fortunate. We have a fantastic health infrastructure. In terms of the physical infrastructure is extremely, kind of right. We have got community-based clinic right at the sort of upazila level, and even at the union level. But we can use this to be able to really kind of take it to the grassroots, and that's going to be really important in terms of taking it forward. Mirza bhai, do you want to come in for any reflections? Because I think I can see you.
Can you hear me?
Yeah.
Okay. Hello, Diana. You remember me? Okay. Okay. But not really. I mean, there was a confusion in one of the slides, Mehnaz. There's something about compliance. I mean, it didn't explain that. But Can you trace it, Mena? The something on compliance.
Yes, the compliance we meant once you've registered, you go and get your vaccine. So we found that most people who registered actually went and did get their vaccine. That's what we meant by compliance.
Okay, so the compliance was very high. That's the point.
Yes. So if people register, then you can be sort of sure that they will go and do it.
Okay, so the registration is the critical then. Somehow convincing people, giving them the right technology. I mean, you know, we are, how much is the vaccination level? I think 4%, 5%? Okay.
Less than 5%.
Imagine Bangladesh is trying to go to 20% in the next few months. Can you imagine the logistics and the communication, education program that government will have to take to educate people how to register, which is, think of some non-literate person. It's a big deal, you know. He or she will need to go to someone to take help. And I have heard there are already businesses opened up in terms of helping out people doing registration, like in passport and in other cases. So I can see that would be the serious problem that government is going to face in the next few months when they have the sufficient number of vaccines and they have to roll it out in the next few months, going up to 20%. Any reflection on that?
Yeah, Mena's.
I think, I mean, with our current stage of digitization, people are very comfortable with assisted access. Even here, we find that for the online registration on Shurukha, most people had someone help them. Some people went to the shops. So only for people who went to the shops, they probably incurred a small cost, but otherwise people ask others to help them out. So I think we are sort of ready for that. People know that they'll get help. They know where to get help. But on the logistics side, of course, that's, yes, Dr. Shakira.
May I answer? I'm as a focal person of communication materials. So how it works, when we are planning to communicate through all the we want to include vigorously to the people. So we try to engage all the development partner and the NGOs. We from the Director General, we call them on a meeting and we call them for our help. So some of the NGOs come to us, like the Shujer Hashi and Red Crescent, and also BRAC and others NGOs, and also A2I Digital Center. In our every upazilas, we have a digital center, and a digital center help people registration is completely free. So registration is not a problem in our country. Every people knows about the digital center. From villages to the urban areas, they go there and just get registered. And from the logistic and the vaccine, when we have the available of vaccine, I want to share my experience on our MR campaign. Only 1 month, we vaccinated around 3 to 4 crore children on MR campaign, only 6 weeks. So we think we are capable to get vaccinated in a month. I think our targeted is 2 to 3 lakh we can easily get administered per day. So it's easily logistic and other support we have. And regarding the communication, it's our policy. As I mentioned before, we don't have the vaccine, not that much of vaccine in our hand now. So we are slow our communication process. So we already aware of it. When we have all the vaccine, like our target is to cover the 80% of population, who is vigorously transport and communicate all the materials.
Thank you. Thank you. Thank you.
Can you hear me?
Yes.
Okay. In terms of involving NGO that the person just said, I mean, are they doing it voluntary, or government is going to fund them in terms of mobilization and other forms of logistics? What's the government
These
plan?
are, yeah, these are, we call them NGOs, and these are involuntary. They do it voluntarily and they don't take any money from the government. This is voluntarily. They willingly come to us and they ask every day. All the NGOs come to us. They are willing. How can we help you? Like USAID and all the NGOs. They come to us and they always asking for us how we can help you, that the vaccination program is smoothly go on. And alhamdulillah, up to still now, there is no problem, and everybody is very much pleased about the registration and the vaccination from the Prime Minister to the root level. Thank you.
Thank you. I think this is where the financing of this will obviously, I mean, the development partners will have to play an important role, and there is, I think, discussion going on that. We don't really have anybody from our development partner community. Otherwise, we could have asked, what is the plan there in terms of financing. But I can see in terms of audience, I mean, I may like to call on some people, and please feel free, because we've got a bit of time, and I think we would love to hear your comments primarily to be able to really finalize, and sort of get this research into sort of more sort of greater use. So any comment that you may have, let's try and utilize that. I would like to wait a bit, if possible, for Mr. Masoom Billah, because he is he's in the Department of Information Communication. We do have love to hear from him about the Shuraka app and the digitization and what the plans there are in terms of really getting this assisted digitization to be really scaled up. So it would be good to hear from him. So we'll give him a bit more time. Otherwise, we'll sort of conclude. But
even there's a question on gender. Would you like to take that, or I can answer that?
Go on, Menas.
So there's a question: do you think government should take any affirmative actions or different design from gender perspective? What are those? So I think the gender, the results that we saw were quite interesting. It is true that women are lower number of women know about vaccination registration, etc. But we also found that those who know it well. Women who know the information, they don't have any confusion regarding eligibility, how to do it, where to get it. In comparison, men, a lot of them know that there's something going on, but they're not sure about how to go about it. So that was an interesting side to it. So, and should there be a design implication? This can be tested, but my hunch is that because we see this important role of community networks, if the main information channel is community networks, then I think we don't need a separate design or special design for reaching out to women. They will get the information and they will be able to come out. We don't get any indication that there are any special barriers for women other than just access to the information. I don't know, Imran Bhai, if you want to add on to that.
No, I think that's good. I mean, the only thing to think about is the digital divide. I think from our other research, so this is not about access. This is about the social dimensions of the access, right? So for women, being on their own, going to even going on their own to for flexi load for a woman is a much more is a kind of a norm from a norm point of view. It is much more difficult because they do have to face lot of challenges and giving phone numbers. There are other people there. So the mediated access, the assisted access, there's a gender dimension of that assisted access, and I think we do need to think about that. Is there anyone else? I mean, I can see Dr. Zaidul Qayyum. Zaid bhai, is there anything that I mean, if you can hear me, I'd love to. I mean, Dr. Zaidul Qayyum is a health economist, School of Public Health. So would you like to come in if you can hear me?
Sir, I think you'll be able to unmute and speak if you would like to.
Perhaps he's maybe having problem. I can see Zaidbhai, you're on mute. Anyway, Zaidbhai could be unmuted.
Right.
Yes.
Hi.
Yeah. Yes, Zaidbhai, over to you.
Okay. Yeah. Thank you very much. Yeah. No. I was really following this interesting discussion. But one thing I was just looking at it and listening to the presentation. One thing, and also listening from others' comments at how you can influence that people willingness to uptake the vaccine. One of the observations, the government has been very successful doing many things, but motivating people and inspiring them to be part of it. Of course, the system and other things, the registration, that's an issue. But how the other organization in playing an important part can influence the people's decision. Of course, the community as such. I mean, like I personally have been telling people, even within the family, somebody is saying that, no, I don't want to take a vaccine. I mean, these things are there, we know. So I was just thinking how far the government could link with the people or the other organization to make people understand that this is important and you can do that. We know the problems are there, the registrations problems and other things, those are there. But, if you can motivate people to make clearly understand that what is the need and what we have been calling that creating a demand. And in those respects, I think we need to do a little bit more in that perspective. And then involving people or others, particularly the other organization, and also the community level or a small organization at the community level in those respects to kind of motivate and create demand. So that was, I was just really thinking. And another observation I was just thinking in the presentation of the study as well is trying to look at mostly the rural population and the urban slum. So I kind of saying that, that's the thing is fine in a sense that you kind of target some of the population. But even in urban, other population, which could be not only the slums, but the population who are even educated enough, but not taking it. But again, so you can see some of the examples where particularly in the one example I can say in UK that has been really today recently, the home care has to be, they're thinking of making it compulsory. But at the same time, we were listening to some of the people saying that, no, I will not, I will rather leave the job. So these are all kind of a thing that we will face, trying to bring in people and then saying that how to motivate them and saying that, no, this is important. There are population we are really going for when it's my turn and trying to call these people NHS and when I can get vaccinated. I know they are bringing the young generation. So there will be some disparities or even understanding of the perception. So it is just trying to say that, yes, it is safe. People are telling about it safe. And then, accepting that and people have their attitudes in that bringing something in foreign to their body and making them understand that what can happen, what cannot happen. We know all these things about many other vaccine, but these things are, we need to do a lot of us. It's not like a simple health education for don't smoke, do more exercise. There are something which is vaccine, but we also know that how EPI is successful is somebody very well known, UNICEF or the kind of people who we bring in well known people, celebrities, and then they tell the story. And it's always successful for child immunization because they know the value of the life of child. But here we have to kind of do a different thing, and maybe on much more telling people the externalities and helping others and then protecting others also yourself. That's a kind of a general view or statement I just would like to make. Thank you. Thank you very much. I'm here.
Thank you. Thank you, Zaid. Do we have the third discussant? Otherwise, I think we will hear from a few other people. I mean, I want to give, I think Diana, if you want, I think I can see Mirzabai wants to say something, but maybe go back to the two discussants we have if they have some final thoughts, and then we can, and then to the presenters, and then we can conclude. Mirzabai, do you want to come in, or is it the old hand, or is it a new hand?
It's the old hand.
Okay. Okay, so you don't want to. You don't have anything to say. You don't have to.
No, I don't actually.
All right. Okay. Thank you, Mirza. But let's go to the two discussants. Diana, do you? I mean, after hearing all this, is there anything else? Any other thoughts that you have? Any other reflections?
So I have two reflections related to the research focus. The first of those is that I think it would be interesting to identify low-income urban settlements which had particularly high registration, and try and understand what are the distinguishing factors around that. So I'm not sure whether the sample is good enough for you to pick that up, or you could identify them in some other way. But I think that would be interesting to understand. What are the situations in which registration, understanding of eligibility have produced better vaccination results? And then secondly, you mentioned in your suggestions registration booths, but I think it would be interesting for the government, perhaps with you, to experiment, to maybe gather 4 or 5 different ideas and just try them and see which one works best.
Great, thank you. Thank you, Diana. I think this whole idea about a positive deviance type of approach, I think would be very, very useful. And, we can discuss this a bit more because, there is obviously a research, Diana, that you guys from COVID Collective is sort of trying to drive around vaccination, and we can basically discuss whether there are opportunities through which we could extend the work that we are doing, that we have done here. I think the sample is large enough in terms of urban slum to be able to detect at a slightly more disaggregated level, but let's see what we can do. Dr. Sultana, is there any concluding thoughts that you may have?
So Dr. Sultana has just left the call.
Okay.
She had to attend.
Fine. Okay.
And Masum sir has not also joined. So Imran bhai, if you have any concluding comments.
Okay, now I wanted to go back to the researchers, Mehnaz and Ishmam and Abindo. Do you have any final reflections, final thoughts?
No, just in general, I think this was a very helpful discussion for us as well. There are aspects that we did not think about or did not notice before. Thank you so much, all of you, for your discussions, especially Diana's point on how we can use this COVID vaccination program as an opportunity to establish new relationships or improve relationships between state and societies. That is something that we can explore, and hopefully we will have opportunities to do more research in this area. So thank you very much for your intervention.
Great, thank you. So in terms of conclusion, I mean, first of all, I want to thank everyone. Dr. Sultan has left, but I think she made some really important points about about where we are. And I really hope that, the sort of optimism about being able to really scale this up rapidly in 2 to 3 months to be able to, this is a massive scaling up. I think it's good to be optimistic, but I think there should be a pessimism of the intellect that I think is important here, because the failure of this is going to be costly. Because especially in terms of our international remittance and international migrants, which is a big part of our economy. We haven't really talked about that. I think this is really, really important for that particular population segment. So yes, it's fantastic to hear optimism, but I think as researchers, we need to contribute to sort of ensuring that that the things will actually happen, and sort of raising kind of areas of focus that would be important. And I think in our research we have identified, I think the urban slum in particular to be a very important hotspot. The youth, the urban slum and youth, these two population segments, and really focusing on the nuts and bolts of getting registration up. And I think as we delve into each of these, there's going to be lots of sort of microsurgery that would be basically needed, lot of implementation research that will be needed, and I hope that BIGD would like to be part of those to sort of support in that way through sort of that type of implementation research. So we're very interested in that. And as of finally, I would like to say that this is, as to say now, the whole it used to be live and livelihood. Now I think we're talking about vaccine and variant. So I think this is also I think luck is on our side, but I think we should always also be sort of cautious that we need to get the vaccination rolled up as soon as the supply side challenges get sorted out, and we hope to, BIGD, as I said, hopes to be a knowledge partner in this whole exercise. I would like to thank everyone. We have the report available of this research that we have done. So this is available on our website, and where we will be kind of also sharing with everyone. So that is available, and again we hope to do more work in this space, and look forward to engaging with you in the future on this very important topic. So thank you all very much.